Hello, good morning, everyone. Welcome to the ninth and final webinar for Working with Children and Youth with Complex Mental Health Needs, an integrated training project. I'm Renee Ferguson, and as usual, I'm going to be your moderator for today. The final and much anticipated topic for today is exploring some of the needs and issues for children and youth who are living with mental illness and addictions. And we have Dr. Ninan from Child and Parent Resource Institute joining us to present. And in a few minutes, Dr. Ninan will introduce himself to you, and he'll tell you a bit about his work. Just going to move things on. So for those of you who have been with us before, you probably already know that this is a joint initiative between the Canadian Mental Health Association of Ontario and the Ministry of Children and Youth Services. As part of the ministry's systems transformation, this project focuses on three core service areas, and those include targeted prevention, brief services, and counseling and therapy services. The project is designed to offer some foundation training to direct service providers in Ontario who are working with children and youth with mental health needs, specifically complex mental health needs. And I'll talk about what that means in a little bit. Most of the project trainings have already been completed, but you can still find the recordings and PowerPoints by visiting www.complexneeds.ca. And as people know, there were 4 major pieces to this project, including a live inventory comprising of training that's already available on Ontario, and it's living in the sense that you can still upload trainings that are happening in Ontario. So you just go to the website, look under inventory, and if there's a training that you want to promote, you can upload it there. The second is a series of webinars, for which this is the last one, and the webinars really focused on social determinants of health and targeted preventions. Third were a series of 2-day face-to-face trainings that happened in 4 areas of Ontario, so starting in Thunder Bay in October, then we went to Ottawa and Toronto in November, and then last week of January we were in London, Ontario. And then finally, coming up next Monday is a 6-part online course focusing on brief services provided for children and youth with complex mental health needs. So you can check that out starting on Monday. If you haven't already registered, I strongly suggest going to the website www.complexneeds.ca. And in addition, we've started a series of French trainings that have that started in January and will be completed in March 31st, 2015. And again, you can check out the website for more of those details. Specifically, what do we mean when we say or when we use the term complex mental health needs within this project? Well, we're really talking about children and youth who are experiencing significant, multiple, rare, or persistent mental health challenges that impact their functioning in most areas of their life. So we're thinking about home, school, community, relationships. Examples of this are, but they're not limited to, children and youth who are living with co-occurring disorders, multiple diagnoses. So these are some of the things that we'll be discussing today. Living with disorders impacted by things like social exclusion, which we've spoken about throughout the last 8 webinars, involvement with the justice system, having histories of trauma. So these are children and youth who are in high need of multiple coordinated services and resources, whether or not they actually receive them. So we're really also thinking about those young people who slip through the cracks or fall through the cracks. And then finally, for this project, we've always considered youth as young people up to the age of 29, so really considering those young people who are part of that transitional age group. So a reminder to check the website, www.complexneeds.ca. There you can find my contact information to request your certificate of completion. You can find past recordings, resources from, and PowerPoints from past trainings. You can find the registration to get set up for Monday's course on brief service provision, as well as other interesting facts and information about the project. So we look forward to hearing from you, and on that note, I would like to introduce Dr. Ninan. Dr. Ninan, you can take it away.
Thanks so much for the introduction there, Renee. So I just wanted to take the opportunity to express my gratitude for this invitation as part of the webinar series here. I typically provide face-to-face presentations, so this is kind of a unique experience for me, but a really exciting one when I think of the technology that we're using here. So certainly hope the audience feels that this is informative and something that folks can take back in their work and clinical practice. So as Renee had mentioned, I'm Dr. Ajit Ninan. I'm a pediatric psychiatrist in London and the medical director at the Child Parent Resource Institute, which is a directly operated facility within the Ministry of Children and Youth Services. I also work at our local hospital at London Health Sciences Centre, and am part of the faculty at Western University Schulich School of Medicine and Dentistry. I do a bit of research as well and am involved in teaching undergraduate and postgraduate trainees. So that's a little bit about who I am. I've been asked to chat to you today about concerns around substance use and related conditions. So that's what we're going to be talking about this morning. Just to start us off, though, it'd be helpful if I could have folks participate in the following poll to help us ascertain what hat you're wearing today. Okay, so we've got a couple of different kinds of disciplines here: social workers, frontline workers, and it looks like there's categories that we didn't think of on the poll, so there's quite a variety as well that's coming up. So really good to see such a diverse audience here. Okay, so in starting our presentation, I thought to maybe start off on a little lighter note, and I'm going to watch a video here depicting effects of recreational drugs. Okay, so hopefully everyone enjoyed that lighthearted attempt to depict what it might be like to be under the influence of substances. What we're going to focus on today are particular drugs of abuse that are outlined in the following slide here. So we'll talk a bit about most of these. And some examples of what we're talking about are also highlighted on the slide here. So I'll just move us along. Another poll. So in Canada, what drug do you think is most commonly used in youth between the grades of 7 and 12? sort of see where the guesses land. And that's certainly quite intuitive for sure. A couple more polls are coming in. All right, so it looks like most people would be guessing cannabis and alcohol. And in fact, that would be right. And actually, alcohol does come in first. So CAMH in Toronto in 2009 commissioned a study looking at kids in the population of grades 7 to 12, excluding corrections and kids on reserves, inquiring about drug use. And the results of their study showed that 58% of kids in those grades had experiences using alcohol. Cannabis was actually at 25%. So thinking about that, it's pretty staggering that many kids are being exposed to alcohol and cannabis. Those are pretty large numbers. Moving on down the list, prescription opiates, almost 20%. Tobacco at almost 12%. Cough medicine, 7%. And inhalants at 5.3%. I mean, these are pretty staggering numbers. When we ask about the lifetime prevalence rates for substance use disorder in adolescents by public sector, what we're referring to are problematic patterns of using those substances as opposed to just any experience. So again, these are problematic patterns of using substances. So overall, in the past year, in this age group, prevalence rates for, again, patterns of problematic use was 24%. So that's pretty staggering. 1 in 4 individuals are actually diagnosable with having substance use disorder in adolescence. That's a large number of adolescents. In the child welfare sector, 19.2%. School-based services for the emotionally disturbed had a prevalence rate of 24%. In a mental health population, numbers increased significantly to 41%. And in youth justice, 62%. That's a whopping amount of prevalence for substance use disorders in the adolescents that we see. So the evidence really points to the fact that substance use is quite prevalent, especially in the populations that our audience would be involved with, youth justice, mental health, etc. This was a study that Aaron et al. Did in 2001. So given the significant prevalence rates, it really makes sense to have clinicians and folks that work with this population be mindful of these concerns. So what we're going to be touching on today are what we call substance-related and addictive disorders. That's the title of the category of these conditions that are listed in the new DSM-5. And this is the 10 categories that are described in the new version of the DSM. So the DSM-5 actually categorizes substance concerns in these 2 general categories. So the first one is substance use disorders. So that refers to problematic patterns of using substances. The second one, substance-induced disorders, is essentially that the substance is actually triggering a particular characteristic set of symptoms that could be an intoxicated state. So depending on which substance you're using, an intoxicated state presents in a particular way. Withdrawal states could be possibly induced by substances. And substances can also induce characteristic mental health presentations. So that's how the DSM-5 organizes substance-related and addictive disorders. So let's review through what the DSM-5 means when they talk about substance use disorder. So the kinds of things that are presented with when someone has a substance use disorder includes tolerance. So tolerance means that an individual is required to use higher and higher amounts of a substance in order to produce the same effect. Or it could mean that using the same amount of the substance over time produces a reduction in effect. So that would be what tolerance is about. And again, substance use disorder could have several of the following symptoms present. Withdrawal symptoms. So this essentially is when the individual ceases using the medication, a characteristic pattern of concerns present that really depends on which particular substance was ceased. A third potential symptom would be cravings, and that's obviously longings for the particular substance. Number 4 is that the substance is taken longer or in larger amounts than originally intended. So for example, you might intend to head to a location to take, let's say, 1 or 2 drinks, and you end up as a pattern of doing this to actually consume 10 to 12 drinks, or you're spending 10 hours in the bar when you intend to spend an hour. And again, it's a pattern of this. So it's not a single isolated event of doing that, but a pattern of problematic concerns. The next symptom that's described is a persistent desire or unsuccessful effort to control use. So essentially that the individual may be aware of their problematic use and has the desire to change because they're recognizing that it's associated with problems in their life, but they've been unable to do so. The next possible criteria is excessive time in activities to obtain the substance. So you find that a lot of time is allocated to finding, using, or associating with events related to the substance that's desired. These concerns can also lead to failure to fulfill major obligations. So when you think about our adolescents, failure to show up to school or show up to work, or having significant problems at home, maybe a little older, failing to attend your child's birthday party or graduation. So major obligations go unfulfilled. There's also persistent social or interpersonal problems that arise. Activities could be given up, whether from a social domain, occupational, recreational. Folks with substance use disorder tend to continue using the substances in hazardous conditions, such as driving, so under the influence, a high risk situation. And even when explaining to an individual with alcohol concerns that they now have liver disease and other physical health manifestations of their substance use, that despite that knowledge, it's continued to be used. So another poll, I'd like for folks to indicate if you are working or have worked with a youth who has or had a substance use disorder. Keeping in mind, these are problematic use that's patterned and persistent. Certainly looking like the vast majority of the audience has worked with youth who have substance use concerns, for sure. All right, good to know. Now, the symptoms that I mentioned previously, the way that the DSM-5 describes the degree of severity is in how many of those symptoms are present. So it's thought that if 2 or 3 symptoms are present, that it's considered fairly mild, but a diagnosable condition. 4 to 5 symptoms present would be more moderate, and 6 or more symptoms are more severe. So that's what substance use disorders are about. We're going to move in now to some of the substance-induced conditions. And I thought to start off with a condition that's called delirium. Really to start off with this because this is a medical emergency. So what delirium is that there is a significant change in the baseline of a person's presentation, so that they appear to be in and out of alertness. Their level of consciousness can be altered. They can be quite disoriented, meaning that orientation to person, place, and time can be really compromised. So for example, a person in a delirious state may not be able to tell you an accurate date, including the year. They may not be able to tell you where they're currently located, what city they're in, and they may not even be able to tell you who they are. So it's to that degree of disorientation. It's a fluctuating course. So it's sort of an in and out of this kind of state. And it happens pretty quickly. And that's differentiated with a condition like dementia, which is a course that is usually prolonged and more insidious. Delirium occurs pretty quickly with alternating levels of alertness. What you see with this altered state is high distractibility. So it's very difficult to pay attention for these individuals. And their short-term memory is significantly compromised. They could present with a lot of really unusual behaviors, very disorganized in their thinking, hard to put concepts together in sentences. They could even have overt psychotic symptoms like hallucinating, especially in the visual sense. So things are conjured up that look extremely real to individuals but are not based in reality. Or they could be involved in having delusional thoughts, so ideas that are not based in reality, like feeling that people around them are extremely evil and about to murder them, as an example. So that's what we refer to as delirium. Now, some of the substances in intoxicated states that we're going to talk about can actually present with delirium. So keep it in mind, this is a medical emergency. When intoxicated states occur related to substances, the ones that are listed on this slide are all capable of causing this. So alcohol, cannabis, hallucinogens, inhalants, opiates, sedatives, hypnotics, anxiolytics, as well as stimulants. Delirium can actually also occur in withdrawal states as well. So if people stop these medications after using for a prolonged period of time, abrupt cessation of these substances could actually induce a delirious state. And these are present for the substances that are listed on this particular slide. So alcohol, opiates, sedatives, hypnotics, and anxiolytics. All right, so what we're going to do is to talk about each of these categories in turn and further explore some of the induced conditions from substances. We're going to start first with alcohol. All right, so I'm going to guess that most people have either seen someone who is intoxicated on alcohol or at least seen it over the media. So perhaps this won't come as a surprise to folks, but with alcohol intoxication, you tend to see significant mood swings. There could be to the degree of being belligerent or aggression. We often see slurred speech. Their coordination is very compromised. The ability to concentrate and retain memory of events can be compromised as well. They can be unsteady on their feet, and their balance can be quite off. Nystagmus could also be seen. What nystagmus is when you've got rapid movement of your eyeballs in a horizontal plane or potentially in a vertical plane. Stupor or coma could be seen as well. And for a variety of reasons, alcohol intoxication can be fatal. Alcohol can slow down the brain and other key organ systems that could lead to fatality. So pretty significant concern when your alcohol levels are quite high in an intoxicated state. When someone is experiencing withdrawal from alcohol, that would typically occur when using alcohol on a pretty frequent basis for a period of time, and again, ceasing alcohol too quickly. So what can be seen with alcohol withdrawal includes sweating or having a high heart rate, so above 100 beats per minute. Tremors can be associated with this, difficulties with sleep, nausea, vomiting, even having, again, hallucinations. And typically, it would be more on the visual end, but you could also have auditory or any other of the sensory modalities. Illusions could also occur. So what do we mean by illusions is that people could see a particular object, say, for example, a towel draped over a door, and be absolutely convinced that that towel is a person. And so illusions are based from actual objects and sort of distorting what the image actually is versus a hallucination that could be conjured up out of nothing. Agitated states, anxiety can also be present with alcohol withdrawal. And then we start to get into the more concerning aspects, and that includes seizures, which in 5% would lead to further complications, including hallucinations and that delirium condition that we mentioned previously. So certainly alcohol withdrawal could be very concerning if not assessed and treated accurately. When someone is in withdrawal, the symptoms usually begin within 12 hours after they stop the alcohol, or there might be a significant reduction in the alcohol use. The intensity of their withdrawal symptoms usually occurs by about day 2 of them stopping their alcohol. And the symptoms generally resolve within about 4 to 5 days. So that's the general course of alcohol withdrawal. Okay, so we talked about alcohol-induced disorders, specifically intoxicated states and withdrawal states. Now we're going to get into the alcohol-induced mental health presentations. This is a listing of all the possible DSM-5 described mental health conditions associated with alcohol. So again, the individual would consume the alcohol. These symptoms would emerge shortly after the alcohol use, or could even occur during the withdrawal state up to within a month after ceasing the alcohol. So alcohol-induced disorders could include a psychotic presentation, bipolar disorder, depression, anxiety, sleep disorders, sexual dysfunction, neurocognitive disorders, and like we talked about previously, delirium. Let's just sort of take a poll at this point in time and see if folks can recall which of the disorders associated with alcohol can be fatal. Would that be alcohol intoxication, alcohol withdrawal, delirium, or all of the above? Looks like it's mainly split between alcohol intoxication and all of the above. Getting a A couple more polls in there. All right, so yeah, it looks like folks are split between all the above at 82% and alcohol intoxication at 16% and delirium at 2%. So the answer actually would be all of the above. However, as I mentioned in the slides there, alcohol intoxication by itself could be most prone to fatality given its compromise on various organ systems in the body. Intoxication withdrawal are associated with delirium, and delirium is a medical emergency that can be associated with fatality as well. So certainly all three conditions are quite concerning. Let's move on to cannabis. So when we think about cannabis intoxication, there's a couple of characteristic symptoms that occur. So having red eyes, having the munchies, dry mouth, rapid heart rate could be possible as well. Cannabis intoxication is usually associated with a state of euphoria. However, it can also have anxiety and fearfulness associated with intoxicated states. People have time-space distortions, poor coordination, social withdrawal, and the presence of hallucinations and delusions could be present with cannabis intoxication, although they're fairly rare. Take another poll here. Cannabis-related problems include which of the following? All right, well, let's take a stab at this. What do folks think? Cannabis-related problems could include which of the following here? Cannabis withdrawal, psychotic disorder, anxiety disorder, sleep disorder, delirium, physical health effects, C and D, all of the above, or none of the above? Okay. So I think most people are going for all of the above and some percentage with the anxiety disorder. Polls are almost closed. Okay. So in fact, the majority of folks are right. All of the above can be associated with cannabis use. So we're going to cover that in the next few slides here. We talked about intoxicated states on cannabis. Let's talk about withdrawal. So the interesting thing with withdrawal is that typically you'd only see withdrawal from use of cannabis when you have a prolonged and pretty heavy use of cannabis. But these are some of the symptoms that are thought to be associated with it. Irritability, anger, aggression, anxiety states can be induced along with depressed states. People may have difficulty with sleeping. Instead of having the munchies, there's a decrease in appetite. Feeling restless. There can actually also be physical discomfort, like abdominal pain, sweating, fevers, chills, headaches, etc. So certainly uncomfortable. Having said that, the vast majority of people who use cannabis do not typically experience withdrawal symptoms. And when the symptoms occur, they usually begin within a 24-hour period of time after stopping marijuana use. And again, peaks at around day 3 or 4. The symptoms of withdrawal typically last between 1 and 2 weeks. So that's what cannabis withdrawal may look like. Cannabis-induced disorders could include things like psychotic disorder, anxiety disorder, sleep disorder, and delirium. And I think this point really doesn't get portrayed much in the media, but the health effects of cannabis would include the fact that it has more carcinogens than tobacco smoke by itself. So that's a concern. Chronic breathing problems could be associated with the effects of cannabis. Cancer, is questionable. People have certainly looked at studies related to impairment in overall intelligence as well as motivation associated with cannabis. People have actually looked at the possibility that certain areas of the brain are actually decreased compared to people who don't use cannabis, which include areas of the brain like the hippocampus, which is associated with memory, and with the amygdala, which is associated with being able to control emotions. Other effects of cannabis include gum disease. It could lower testosterone, sperm count, and decrease fertility. So there are a number of physical health effects and other effects related to cannabis use. A question often gets asked of whether or not marijuana could cause schizophrenia. And it's noted that a vast majority of people who use cannabis do not actually develop psychosis. However, it is thought that use of marijuana does increase the risk of psychosis, and the more pot you use, the increased risk is more present. If you look at people who use marijuana and then develop a psychotic disorder, as compared to people who don't use marijuana but develop a psychotic disorder, it appears that use of marijuana actually allows you to experience your psychotic disorder earlier, by about 2 years. So those are all fairly significant risks when it comes to schizophrenia. But as was mentioned in the first point, the vast majority of people who use marijuana do not develop a psychotic condition. And the risk of schizophrenia, or the added risk of schizophrenia when using marijuana, appears at this time to be about 0.5%, or 1 in 200. Okay, so now that we've covered some information on marijuana, as you guys recall, it was the second highest use in adolescents, with alcohol being the first. Are folks feeling more comfortable talking to the youth that you work with about the risks of cannabis? All right, so the majority of people are looking like they've got some additional information to share with folks and some additional things to be concerned about with their youth who are using cannabis. All right, let's move on to hallucinogens. So these are examples of hallucinogens, and they go by a number of different street names, depending on the particular example of the hallucinogen. So with hallucinogens, the effects of these substances vary depending on the particular substance that's used. So a hallucinogen like salvia could last for minutes. Jimson weed could last for a day or more. There are no withdrawal symptoms that are described with hallucinogens, and they're not known to be as addictive as some of the other substances that we're covering. However, people do have what is called bad trips, and these are typically very fearful hallucinations that are conjured up, or really scary kinds of thoughts in the forms of delusions that make people feel pretty freaked out about the experience. And so people can be quite petrified, scared, maybe convinced that of an idea that wowould be of significant safety risk, like feeling that people are trying to kill you, or thinking that you could fly off a 50-foot building or so. Overdoses can be fairly lethal with hallucinogens. And in general, when people are using hallucinogens, our medical treatment would be observation and reassurance. Given the fact that there can be complications that occur, but it's not so common. Hallucinogens can induce particular disorders, including psychotic disorders, mood disorders, anxiety, and there's delirium again. Let's move on to stimulants. So again, when we talk about intoxicated states of stimulants, what we're seeing is large pupils. So as we go through these symptoms, people can keep this in mind about what sort of things to look for when you've got a youth presenting not at their baseline and you're suspecting some substance use. Stimulant intoxication will look like this. Large pupils, their breathing becomes pretty shallow. They're engaging in like grinding of their teeth. You see a lot of excessive movements or repetitive movements. Sweating can be part of the picture. Their mood can be elevated. And as we move into the more concerning elements of stimulant intoxication, we're talking about significant problems with heart rate, complaints of chest pain, high fever, hallucinations. So some of the more common hallucinations to experience with stimulant intoxication includes what's called formication, which is that feeling like you've got ants crawling underneath your skin. You might see someone scratching away at their skin excessively. Paranoia can be part of the presentation as well. Confusion, seizures, or even a coma state can be experienced with stimulant intoxication. Bath salts is a fairly new phenomenon, and why I thought to include this in the presentation is that bath salts are actually chemically related to amphetamines. So we talked about what you see with stimulant intoxication. With bath salts, so it's chemically related to amphetamines. It can be sold online. It's fairly readily available to folks. Euphoria, increased sociability, and sex drive is also increased. Some users would experience paranoia, agitation, delirium that's associated with hallucinations. Some folks would even engage in psychotic or violent behavior, and deaths have been reported with bath salts. So those would all be concerns associated with intoxicated states with stimulant medications, including bath salts. When we look at withdrawal from stimulant medications, we tend to see some opposite features. So instead of euphoria, we would see a dysphoric state. In fact, stimulant withdrawal can present with a massive state of depression. And along with this depression, one of the major concerns is that there's a tendency for the depression to include strong suicidality. So that's something to be very cautious of with stimulant withdrawal. Sleep disturbances can be present, really vivid and unpleasant dreams. Stimulant withdrawal, would also include low energy levels and increased appetite. Psychomotor agitation or retardation refers to thoughts and movements being sped up or in an agitated state, or sometimes even slowed down. Stimulants can induce particular conditions, like we've been talking about all along here, including psychotic disorders, bipolar disorder, depression, anxiety, obsessive-compulsive disorder, sleep concerns, sexual dysfunction, and again, delirium. We're going to move on now to inhalants. So folks might be wondering what the individual depicted in this picture is using, and those are whipped cream dispensers. There is nitrous in whipped cream dispensers, which people abuse as an inhalant. Inhalants are also found in things like spray paints or whiteout, lighter fluids, hairspray, and paint thinners and such. So these are some of the creative ways that our kids have abused inhalants. The thing with inhalants is that because of the route of absorbing an inhalant, the effects of these are very immediate, and they're usually quickly out of your system as well. So the effects usually diminish within about 15 minutes. But given the way that it comes into the body, it is inhaled into the lungs. The lungs are very profused by blood from the heart, and blood that's picking up oxygen around the lungs will pick up the toxins associated with inhalants and deliver those toxins straight to the heart. And one of the first major organs that the heart pumps to after it takes care of itself is the brain. So the lung, the heart, and the brain are all organs that are majorly affected by inhalants. In intoxicated states with inhalants, these are the set of symptoms that you typically would see, including euphoria. And as I read out some of these, you'll begin to notice the similarities with alcohol intoxication. So there's dizziness, coordination and balancing problems, slurred speech, tremors, visual problems, movements are slowed down almost to the point of lethargy, unresponsiveness, coma states could occur. And as I mentioned previously with the organs that can be involved, people can experience such lung manifestations that suffocation occurs, or there's a heart attack and their heart stops, or you could have major brain damage occur. So the potential concerns associated with inhalant use are quite severe. Inhalants also induce other mental health disorders like psychotic disorders, depressive conditions, anxiety disorders, other neurocognitive disorders, and that really speaks to what we talked about earlier with brain involvement. So significant concerns around cognition and other neurocognitive concerns, delirium also being a part of the picture as well. All right, this is an example of the opium plant found naturally. So we're going to talk about synthetic opiates. These are examples of opiates that we've been able to synthesize, and some of these you would recognize as what might occur in a medical setting, so using things like morphine or codeine or hydrocodone. Methadone and buprenorphine are used to help people who are addicted to opiates. When people are abusing opiates and intoxicated states are present, what we typically would see are states of euphoria. And we talked about in intoxicated states for stimulants, you usually have like large pupils. In opiate intoxication, you have pinpoint pupils. So these are really small pupils. So again, thinking about how are you going to recognize what potential substance use a particular kid that you're working with may be using, these are some symptoms to keep in mind of. With opiate intoxication, it tends to slow you down. So opiates are used for pain relief, and sometimes sedation comes along with that. So in intoxicated states, you'd see sleepiness, perhaps slurred speech, impaired memory and attention, again, stupor or coma. And opiates, because they slow your system down significantly, they could slow you down to the point of compromising your breathing. So your breathing is so slowed down that it could be fatal. So when we think about withdrawing from opiates, what we tend to see are like flu-like symptoms. So it's kind of a wet condition. So large pupils, so the opposite of the pinpoint pupils would be present. We see goosebumps, sweating, yawning, difficulty sleeping, congestion, watery eyes, muscle aches. Those kind of sound like flu symptoms. Nausea and vomiting, stomach aches and diarrhea would go along with that picture as well. Fever can be present. You can also have anxiety and irritability, dysphoric or depressed mood states present as well. And with mental health disorders that are induced by opioids, these include depression, anxiety, sleep disorders, sexual dysfunction, and delirium as well. All right, decades ago, Xanax was thought to make us better moms. That was an actual advertisement some time ago. Hopefully people are not feeling that way these days. Lorazepam, clonazepam, diazepam, that's Valium or Ativan, those are brand names. These are examples of medications that are prescribed for anxiety or seizure disorders. Ambien and Imivane are other medication examples that are used to help people with insomnia. These medications are highly addictive and have abuse potential when they're not used in the way that it's prescribed. Intoxication and withdrawal are actually quite similar to alcohol, and these type of medications are in a similar category of substances that alcohol is in. So the intoxicated and withdrawal states would be a very similar characteristic picture that alcohol would present with. So thinking about what conditions are induced by these substances, the list is, as you see before you, psychotic disorders, mood concerns, anxiety, sleep, sexual concerns, neurocognitive difficulties, as well as delirium. Okay, so let's take another poll here. In my experience, youth with substance abuse issues often have another mental health issue, like depression or ADHD. Let's see if folks have that experience or not. There's people who present with substance concerns, but also another mental health issue along with that substance concern. Certainly looking like a lot of people experience kids who have both going on, mental health concerns as well as substance abuse concerns. So about 91% are experiencing that. So the question really gets asked then, well, what comes first? Does someone develop a mental health presentation and then self-medicates with substances to alleviate the suffering associated with that mental health concern? Or, as we talked about in this webinar so far, does it start with using a substance and that substance induces the mental health disorder? So which starts first? Well, so we can talk about having a secondary mental disorder. So that's a primary would be the substance use. Or maybe this substance use is secondary to the mental health concerns. There certainly are common factors in any of these. But how we go about assessing this particular situation is if mental health symptoms were not present before a substance use, but perhaps occurred after, then that would be more likely to be a substance-induced mental health condition. Symptoms could start during or shortly after intoxication or withdrawal. So the time frame that we usually give is within a month. So that would be a substance-induced disorder. What we typically see too is that symptoms persist for a substantial time after use has stopped. So the symptoms would occur for longer than a month. And those set of symptoms is when we have a substance-induced disorder present. It is difficult sometimes to ascertain the exact timeline. What we do know, though, is that depressed adolescents are twice as likely to abuse or become dependent on cannabis. Young adults with a history of an anxiety or depressive concern may be twice the risk for later drug use. And in clinical studies of adolescents with substance use disorders, the onset of a major depressive disorder most often follows the onset of substance use disorder. So it's a secondary depression. So this is depicting the relationship between mental health concerns and substance use disorders. When we think about the question of, well, people have in the past thought you can't really treat the mental health concern until the substance concerns addressed, or vice versa. There had been some confusion around what to treat first. So some studies looking at this depict, for example, a 16-week random control trial of 126 youth who have depression, and along with that depression, substance use concerns. In this study, a medication called fluoxetine, or Prozac, was provided, as well as some psychotherapy for the substance use concerns. So it was combined therapy. And that was compared to the adolescents who received a placebo medication and psychotherapy. So what happened was that depression was improved in both groups, but the combined therapy appeared to be more effective. So for those whose depression remitted, so when these individuals with both substance use concerns and mental health concerns, specifically depression, were treated for their depression, they actually had more negative urine drug screens, showed a greater reduction in drug use, and overall did better than those who did not remit. So that really provides some evidence that it really does make sense to treat mental health concerns even if a patient is presenting also with substance use patterns. Questions often pop up along ADHD and drug use. There is evidence suggesting that the long-term use of stimulants when treating ADHD has not been associated with an increased risk of substance use disorders in adolescents. And the idea here is that ADHD is a condition of high impulsivity, so people may make poor decisions that are based on impulse. Treating that sort of impulsivity can help a person think twice about engaging in substance use. So when we talk about medications and substance use disorders, people have used antipsychotics, which are not necessarily helpful for substance use itself, but if there are symptoms associated, like psychosis. Antidepressants might be effective for depression and perhaps for substance use concerns. Mood stabilizers haven't been shown to be helpful with the comorbid presentation, but may potentially be useful for substance concerns. So certainly medications can be considered in the treatment for comorbid presentations. Let's do another poll here. The poll asks, I have effective strategies to help youth with substance use problems. This question is really ascertaining people's comfort level in having some strategies and helping youth who have substance use concerns. Yeah, and the polls are kind of showing what should only be predictive. So sometimes people feel that they have, about 61%, and other people, about 22%, feeling that they do have some strategies to help. And a fewer percentage feeling that I don't really have access to effective strategies. Okay, so in the remainder of our time, we're going to talk a bit about how to approach kids who have substance abuse or dependence issues. This is a slide that depicts stages of change which are related to motivational interviewing. And so when someone is at a pre-contemplation stage, what that refers to is really not having thought through the ill effects of their substance use. They're not really mindful of the concerns that are there. A contemplation stage is when someone moves into a feeling that there's some ambivalence around this. Yeah, like I can do a pro and con list of using substances, and so they're on the fence. They haven't really sort of been sort of dedicated or committed to actually seeking out some treatment. And this varies then with the preparation stage, where someone's made a decision. All right, I've looked at the pros and cons. I really am starting to now acknowledge that a plan needs to be in place to help me with substance use. So that's sort of where that person's at. And in the action stage, that's really they're involved in active treatment. And when they enter into maintenance stage, that's sort of all about relapse prevention and maintenance of sobriety. Relapses can occur, and that's certainly possible, but the aim is to minimize the degree of relapse. And this is the stages of change model. And this sort of contrasts when you're in a particular stage of treatment, how do we, as people who engage in providing treatment, match up depending on what stage they're presenting with. So in the pre-contemplation stage, when someone's not really acknowledging the ill effects of their substance use, really the stage of treatment that makes sense is just an engagement process. It's listening, it's empathizing, it's understanding, and not really trying to convince the person that they need to engage in treatment, because you'll lose the person. When they're at a contemplation stage, there is some persuasion that's necessary in order to go on for the preparation stage, where they're acknowledging, yes, there is some issues, and I do need to handle this better. When they're in the action stage, that's where an active treatment occurs. And in the maintenance phase, the stage of treatment there is really relapse prevention. So motivational interviewing is all about the following points here. It's about expressing empathy. We really need to build rapport and trust in these individuals that we're trying to help, because without that, you will find it very difficult to move a person through the different stages of change here. There's a need to empower your individuals that you're working with there, so that you can support self-efficacy, because when someone is intrinsically motivated to work on particular goals, that will go much longer than feeling forced into treatment. Developing discrepancy, and it's sort of a gentle way. It's not sort of being really harsh and pointing things out with firm direction, but the more that you can get your adolescents to connect the dots themselves, the better the outcomes would typically be. Rolling with resistance is all about expecting that there's going to be some setbacks along the way and some resistance and such. And it's not coming down harsh on people, but rolling with it and gently being encouraging and supportive with it. That's what motivational interviewing is about. When we are involved in expressing empathy, it's really taking an active approach at listening as opposed to necessarily problem solving every moment. It's conveying interest in your client, acceptance. And you really want to avoid challenging or giving advice at this stage. It's all about understanding their point of view. It's also about establishing personal goals as well. And in order to do that, you need to know what the client's aspirations are. What's important to them? What would they like to see different about their life? What were the things that they enjoyed in their past? And in general, using the terms goals, that's very clinical sometimes and perceived to be very clinical. And again, you want to be able to do what you can, say what you can to really connect and relate to the adolescents that you work with. Avoid discouraging unrealistic goals too. I mean, this is all about what's your aspirations? What do you feel like is really important to you? Developing discrepancy, what's that about? It's about helping your client to see how substance use can interfere with those goals that they talked about, their aspirations and what they feel is important in life. So it's gentle connection. It's breaking long-term goals into smaller, more manageable steps so that those goals don't seem to be overwhelming. The Socratic method is all about asking questions. And again, it's asking questions to help your kids be able to connect the dots themselves so that they're not seeing you connecting the dots for them. That's the Socratic method. To avoid directly pointing out contradictions or discrepancy. And again, like I said before, having more questions so that they can make the connections themselves. Resistance to change is very normal. And so when resistance comes up, the idea is to explore the resistance to change. Let's find out what that's about. Exploring the benefits and the costs of change, et cetera, and avoiding direct confrontation or opposition. Self-efficacy, like we talked about before, is a very empowering aspect of motivational interviewing. Having the client believe that they are capable of change, encouraging them, expressing optimism that change is within reach, reviewing successes in other areas of their life as evidence for them that they can succeed, and also reframing failures as opportunities to endure and experience strength as a result of. Remembering that motivation is what one has and not does. All right, let's take another poll. Both substance intoxication and withdrawal can present with many psychiatric symptoms. I think we're going to have a series of polls here to see what folks recall. Okay, so it looks like 100% people are thinking true, and that is absolutely true. Let's move on. Okay, so poll number 11 here. Which of the following warrants a trip to the emergency department? Changes in alertness is A, B, hallucinations, C, seizures, D, severe physical symptoms, E would be B and C, hallucinations and seizures, or F, all of the above. So it looks like the majority of people are going with all of the above, and a couple of people going with B and C. So the right answer would actually be all of the above. So changes in alertness could be a delirious state, hallucinations. It could be like you're seeing something that's really evil, you need to defend yourself. Those could potentially be quite concerning from a safety risk perspective. Seizures could obviously have their significant risk. Severe physical symptoms could be things like chest pain. There could be organ concerns going on. So certainly all of those concerns have the potential for high risk and should be assessed emergently. Poll 12, mental health problems that develop before use or persist after use warrant treatment. So if you have mental health concerns before you have substance use concerns, or you have it during your substance use or after, does all of that need treatment? A is true, B is false. Looks like majority of people are thinking true, and that's absolutely correct. We have evidence to suggest that treating mental health concerns, even during substance use, is effective. Poll 13, treatment for substance use may include medications. What do folks recall from our brief discussion on that? It looks like people are going with true, almost closing the poll here. Yeah, so I think 100% said true, and that's absolutely true. Treatment for substance use may include medications, and there's some evidence to suggest that. Okay, this is a question on what we covered with motivational interviewing. Is motivation for change intrinsically driven? A, true, B, false. certainly looking like the majority of people are choosing true. And that's absolutely what I would say. So when you've got motivation that is coming internally from the kid that you're using, a much better approach. So helping that person connect the dots, self-efficacy, these are all integral parts in success with working with kids who have substance use concerns. So just to finish off our presentation here, a couple of take-home points. Both substance intoxication and withdrawal can present with many psychiatric symptoms. We covered the different mental health presentations that are present depending on different substances. If you suspect intoxication or withdrawal, seeking medical assistance certainly makes sense. Thinking about an emergency room presentation, if you see changes in alertness, hallucinations, seizures, or severe physical symptoms, that is important. Mental health problems that develop before using substances or persist after warrant treatment. Substance use itself doesn't include medication treatment, but a cost-benefit analysis really makes a lot of sense to provide. Motivation for change is intrinsically driven. So we are at the end of the didactic piece of our time together. At this point, we'll be engaging in a question-answer period.
Thanks so much, Dr. Nynan. That was really informative, and I really liked the polls that you put up as well. Thank you very much. So we're going to throw up the question box. I see that there have been a few people who've had questions throughout the presentation already. So now's your chance to ask Dr. Nynan your questions. So I'll give you a few seconds to put them up. See a bunch of people actually getting ready to respond. Okay, our first question is, would you say that there has been an increase or significant change in the use of cannabis and alcohol versus tobacco over the years?
Yeah, so that's a really important point to make, and certainly there does appear to be an increase in the prevalence rates of substance use in children in general. But as the CAMH study indicated, cannabis and alcohol use have very significant prevalence rates over tobacco most recently. So you're absolutely right that there are significant increases.
Okay. And here's a good question. So do psychotic-induced disorders, and also this person needs substance-induced disorders, persist for a sustained period of time after the substance is no longer being used?
Yes, so they absolutely do. And that is how we define a substance-induced psychotic disorder. So if the symptoms persist beyond a month after stopping, that's when you have the condition of a substance-induced psychotic disorder. And I've seen kids in the hospital who persist for sometimes months with psychotic symptoms. And it can be a very significant source of suffering for that individual.
Okay, and a question about, I guess, differences in ethnic groups, racial groups, gender, around responses to ETOH or illicit drugs.
Yeah, that's a really interesting question. So within different ethnic groups, we've actually done studies indicating associations with genetic differences as well. So, for example, in certain Asian groups, they lack particular concentrations of enzymes that are required in breaking down alcohol. And as such, some individuals who have this particular genetic variability will become more toxic on lower amounts of alcohol than other people. So there are ethnic-related genetic variabilities in responding to different substances. Now, I probably don't have the specifics, but in general, I think that ethnic and related genetic variability could certainly influence that for sure.
Okay, and I guess also thinking about why would that be something important to know?
Yeah,
Or would it?
Yeah, and so in terms of anticipation, one would need to sort of pay attention to particular ethnic groups as it relates to culture around the use of substances, and sometimes some of the environmental pieces will play as equal a role as the individual in terms of treatment. So looking at other cultural pieces or spiritual pieces really makes a lot of sense as well. I was recently involved in a presentation to a church group where we were talking about supports and resilience that are built in with having connections to religious support groups as well. So taking a look at all those factors really makes a lot of sense.
Mm-hmm. And that there's an incredible amount of variation even within those categories.
Absolutely.
People, yeah. Another question about can the substance-induced disorders be prevented? And if so, how do we know that they were caused by SUD and not just by coincidence?
Right. So with permanency from substance-induced disorders, that is absolutely possible. So thinking about the topic on inhalant abuse, so that's a great example of how quickly people can experience brain damage associated with that, some very significant neurocognitive impairment. And that can be permanent. Now, with substance-induced mental health disorders, it is sometimes really hard to delineate which started first, and if it was just a coincidence, or if the substance use is sort of unmasked underlying mental health concerns. So sometimes the way that the time frames work, it becomes really difficult to delineate. But in the end, we have an individual who needs treatment. And so I think the most important point to make is that even if you have comorbid substance concerns with mental health concerns and you're not sure the timing of this, it really does make sense to treat the mental health concern and to treat the substance use concern. We used to in the past think that you can't treat mental health concerns unless you first treat the substance use, and we no longer feel that way.
Okay. There's a question about the stats. So question about why, Dr. Ninan, you used the 2009 stats and then just made reference to 2013 stats that are available out of CAMH.
Well, that's a great informative point there. I'm going to be sure to take a look at the 2013 stats. When we put together the presentation, at the time that we did that and in a review, we weren't aware of the 2013 results. So thanks for that point. I'll take a look at the CAMH updated stats.
Great. And then another question around SUD-induced disorders. Does this mean casual? Can you elaborate, please?
Okay, so there's substance use disorders, which is, as we were describing before, it's a pattern of use that's associated with problems in various domains in life. So those were the earlier slides that we talked about. For example, people are failing to show up to obligations at work, at school, in their personal life. There's tolerance that's developed or withdrawal symptoms, etc. So these are evidence of problematic use of substances. So that's what we mean by substance use disorder. The substance-induced disorders are examples like the intoxication states that we talked about, withdrawal states, or the mental health disorders that are induced by using substances.
Okay.
I hope that clarifies what the individual meant.
Well, sorry, I actually read the question incorrectly. She was saying causal, not casual, and I said casual.
Okay.
Yeah. Another question around parental caregiver. So is parental caregiver use of substance a reasonable predictor of whether or not a child will use or develop an addiction?
I really like that question. So
Yeah.
there are a couple of factors to think about. So one is the genetic vulnerability. We certainly do know that genetics would play a significant role in deciding if someone is on a trajectory for substance use disorders or predisposed to or has a higher risk of developing substance use disorders or related disorders. But then we also can look at other environmental factors like modeling. When parents model coping mechanisms with using substances, that can be very powerful for offspring. And generally speaking, there may be some increase in chaos and stress and adversity in homes that have an individual who's experiencing substance use concerns. And that could be related to mental health concerns. And then we're in a risk for self-medication or associated comorbid substance use concerns. So I like that the question was brought up to speak of that.
Okay, thank you. And then a question, are there opioid-induced disorders listed for each substance related to when a person is actively using the substance or something that they might be at risk for developing afterwards or both? Does that make sense?
I'm going to try and read through that question again. Okay, so the opioid-induced disorder, it refers to symptoms that are actually present and not the risk for that. So in order to be diagnosed with let's say, an alcohol-induced depressive disorder, you would have the history of that person using alcohol, and during their use of alcohol or shortly after stopping their alcohol use, they actually develop symptoms of depression, clinical symptoms of depression. So any of the ones that I listed are all at risk for those particular substances that were mentioned. But in order to diagnose the condition, the actual symptoms need to be present. I hope that clarifies that.
Okay. And then we have a question. Let me just try to... I've recently noticed an emergence of individuals using ketamine at a dependent level. Do you know of any research being done in this area around withdrawal symptoms, long-term effects of abuse, and so on?
Yeah, so the DSM-5 would actually also point out the sort of other category. So that would include medications like ketamine, which was used previously as an anesthetic agent. It induces profound memory loss, like a dissociative amnesia is what it's referred to as. People have used ketamine in an abusive manner to achieve euphoric states and that sort of dissociative amnesia. So there is information that's known about ketamine. There is current research being done on it. It hasn't made its way into DSM-5 as a separate category, but would be included in kind of an other description of substance use concerns.
Okay. I think we have time for one more question, and it looks like a few people are typing. Okay, so here's a good question. There has so far been no mention of trauma. My experience is nearly every person I've met with an SUD has some such history. keeping in mind that trauma is a broad term interpreted very individually. Do you want to comment on that, Dr. Ninan, before
Sure.
you?
Yeah, I really love that point.
Yeah.
It really ties into the other question about parental use of substances. So when I was talking about adversity within the family, what I was thinking in my mind was around traumatic experiences. And like was pointed out, trauma is really in the eye of the beholder, right? So trauma doesn't have to meet DSM-5 description criteria for what trauma is, which tends to be witnessing near death or death experiences and such. Trauma can be witnessing significant family discord or family violence, et cetera. That can be very traumatizing to children. So when you are reacting and have responded to trauma in your life, it can be a very dysregulating experience emotionally, cognitively, and behaviorally. And when things just feel out of control internally within your body, you seek a way of escaping from that, a way of regaining control, or just numbing yourself from the harshness of reality. And so it's no wonder that a lot of people who do experience trauma in their life resort to using substances to achieve that purpose. So thanks for raising that point.
Okay, so that's all the questions that we can take. We're out of time. But again, Dr. Ninan, thank you so much for sharing this time with us and sharing your expertise. We really appreciate that you made time for us today. I'm wondering if you want to have one last sentence to wrap up the webinar, and then we'll...
Sure. Yeah, so thank you so much, everyone, for being such an attentive audience and providing some great stimulating questions, too. I think if I could summarize one take-home point, it would be that it is really important to recognize the potential for substance concerns existing in the kids and youth that we see, because it's so prevalent, as we described earlier, and that it's certainly related to a lot of complications, including death. So there's a high importance for being able to recognize this and to also seek treatment for these individuals. And it'd be, I think, really helpful for folks to take a look at what motivational interviewing is all about, the readiness of change model that is part of that model. It certainly has a lot of evidence base in terms of being helpful. So again, thank you everyone for participating and listening, and it was my pleasure to be involved with this.
Fantastic. And thank you to all participants again from our end. Really appreciate your questions and your positive energy every webinar. And for people who have participated in all 9 webinars, please email me. I'll get your certificates ready and sent out to you. Make sure to email me by March the 1st. Reminder that the evaluation surveys will go out tomorrow. The PowerPoint slides will go up tomorrow on the website. And if you have any questions just around the material or questions around, I see there's one question about whether or not the material can be used, send us an email and we'll connect you with Dr. Ninan so he can answer those questions directly. All right, we really enjoyed working with you, and we look forward to hearing from you soon. Take care. Bye. Hi there. If you're watching the webinar recording, tell us what you think. The link is on the screen in front of you. Thank you.